Hello everybody, welcome to the first episode of the Coronary Corner by SYSTOLE. Our pleasure to introduce this first episode. My name is Yader Sandoval, an interventional cardiologist at the Minneapolis Heart Institute, and I'm here with my partner in crime, Manos Brilakis.
Hello Yader, it's so great to talk to you and kick off this first episode of the SYSTOLE podcast.
It's great. So, we talked about many of the possible themes to kick this off, and I think what we identified would be a very timely thing to discuss is CT-guided PCI, right?
Yeah, CT-guided PCI is something relatively new, although we've been doing CT for so long. But it always amazes me that we have the structural people who have been using CT for many, many years now, and it's considered unthinkable to even plan a case without doing a CT first for the anatomy of the aortic valve, mitral, etc. But for us, although we'll be doing CT for coronaries for even longer, we have not been using it to see planar PCI and use it a little more detailed way, similar to the way the structural people do. But I think we have similar ideas about this. And what are your thoughts about, first of all, should we be doing that? And why should everyone, I think, learn about how to do CT and read the CT and use it to plan PCI?
Oh, absolutely. Well, I think, again, you have to think about like CT has been around for several years, right? So why now? Why 2024, 2025? How did this happen? And to me, it's a lot of elements that came together just at the right place at the right time. CT at this particular point from a clinical perspective, it's now class 1, pretty much broadly recommended to evaluate patients with suspected angina. So we're just using it increasingly more. There were other places around the world that were using CT, like you think about UK and the NICE guidelines, they've had class 1 for CT for many years. But now in the US guidelines, they're also increasingly endorsed. So many of the patients that we are seeing in clinical practice that were coming to the cath lab have a CT first and foremost. And therefore, what's happened gradually is that, and I like to say that there's two paths. Either there's a path that these patients come through with a CT to the cath lab and we don't look at that information, or there's this all-existent array of information that we can evaluate to better evaluate these patients. So again, that's one way to go about it.
Yeah, I completely agree. And it used to be that everyone would come to the cath lab with a nuclear stress test. And we now know that nuclear, first of all, has much more radiation compared with the coronary CT. And the information you get is not always as detailed and not always as useful as the ones we get at coronary CT. So I think with the guidelines, as you just said, we're going to see more and more that the CT is going to be the gateway to the cath lab and for the patients to be triaged for procedures. I agree with you that now there's this critical momentum that we have the awareness, we have the guidelines, but also the machines have been improving quite a bit. 256 slice, you can do a full scan in a heartbeat. The image quality is amazing. Now we have the high resolution coronary CT. So we're getting better and better images that make sense even for us interventionalists. And I think that brings us to the next point, which is how to interpret this. Because with the older machines, poor quality images, it was much harder for people to understand what they're looking at. But now, even interventionalists who haven't had dedicated training, and I haven't had personally, I don't think you had either dedicated like CT training, level 2, level 3, like the fellows now have, even without that, you can still be able to make sense of the images we get with the coronary CT.
Yeah, no, going back, I think there's just a lot of elements that have fallen into place. And going to your point about training, like, for example, like even in my own journey, like I did level 2 training in cardiology and CT, but I went to practice and there's a number of barriers that even people that have trained in CT, particularly interventional cardiologists, have encountered. And one of those was just things as access, right? Like you can go to practice and if you're not part of the general pool of readers that are officially looking at the CTs, you don't even get access to the software. So first barrier is software. Now, of course, the hardware, to your point, the scanners are a little bit better, and now you're looking at the scanners, you're looking at the software. And the question is how, again, it goes back to like, why has this become a real thing now that we're looking at CT? And the reason I think this is now increasingly important is, one, because inevitably, whether we like it or not, it's being clinically performed. Now that it's clinically performed, there's now an increasing number of softwares that are now increasingly being developed for a focus to support us in the cath lab. And a third component that I think is critical is that now we know what we're looking for. So we have a lot of experience from things like intravascular imaging, whether that's IVUS or OCT. It used to be, to me, this is very analogous to my days back in training with things like IVUS, for example, or even OCT. You're like, there's all this array of information. What should I be looking for? But the education has been increasingly been simplified, that we know that we pretty much want to look like from what's been done in intravascular imaging for morphology, length, and diameter, sort of like an MMLD. So it has now been increasingly clear that from CT, we can pretty much look at those elements, right? We can look at a CT that was clinically performed before the patient came to the cath lab, and rather than ignore that data, there's in some way free information that we can pull from that CT to understand where's the lesion, is that lesion calcific or not, how long is that lesion, get some estimates if there's proper vasodilatation and the patient got nitroglycerin and whatnot, or what is the vessel size. So we can really enter the cath lab with way more information. And again, I think to me, a particular message for us that can do today is like, why? Why is this relevant to the practicing interventional cardiologists out there? And to me, it comes because rather than enter the cath lab blind, you can now enter with a good understanding of case complexity, of what guide do you need to use based on the ostium of the vessel. Is the lesion calcific or not? Is this something that is potentially more focal disease that would benefit from PCI versus diffuse disease or multivessel disease that maybe you should even have some discussions about the heart team? So again, there's all these elements that I think we are increasingly learning more and more and more. And it's been really, I think, a very exciting territory because it brings together a lot of people from a lot of specialties, radiologists, cardiac imagers, interventional cardiologists, people that have different perspectives that are coming together at the right time to try to figure out how to do the best for our patients. But you tell me, I mean, I know that there are people always talk like hype, hope, and reality, and there might be some element of hype, but you've super experienced, you've been in practice for many years. I mean, what's the value?
You're calling me old now, I say. All right. When you get experience, then that means you're getting old, but that's a valid point. But the reason, I'll tell you a simple reason why you need to do this. I was doing visiting in, I think it was in Montreal, and they come to me asking me for an opinion, how do you open this CTO? And I'm like, great, show me. And they show me a CT. And, that was a few years ago. I was looking at it like, oh, my God, what is this? I had no idea. So, and, back then it was much less prevalent for us. But I think the end of the day is if you're going to keep your job, you're going to have to read CT because it will become the same as a diagnostic angiogram. So jokes apart, if you cannot read a CT in, I think, a few years from now, you will be outdated. Because many of the patients who already know exactly what is going on based on the CT, and if you cannot tell the referring or tell the patient and plan the procedure, then that's going to be a major problem. So to remain relevant and to be able to get the best, then you need to be able to read a coronary CT. But I think part of the fear is, and I had the same problem, for quite a while, I wanted to learn how to read CT. So I went to the Vitria web station, and I started playing with this, and it was excruciating. I heard videos, and actually the way I learned is actually a lot thanks to you and John Lester and Joao and Victor, our imagers, where they show me like the 5 key things. This is how you open the study. This is that you look at the MIP. This is how you look at the MPR. These are the 3-4 buttons we use. And I think it's the same analogous thing as trying to operate like a car. There's like 20,000 gauges and instruments, but in the end of the day, you need the driving wheel, you need the gears, you need the gas, you need like the 3 key things. And then eventually, you may or may not use the other bells and whistles. So I think the same thing for CT. Part of the problem for interventionalists who don't have experience from their training is that it gets overwhelming. You have so much stuff, so many buttons to press, so much information. But once you simplify it, hey, this is the button to open, this is the button to get the MPI, this is the button for MPR, this is how you modify it, like the 3-4 key functions. And then once you start getting some of the key things, what to expect when you press those buttons, life is much, much simpler. So this is why I think you need to do it, because you have to remain relevant, But as far as the how, I do think it helps to get someone guide you through the first steps. It's the same as in the cath lab, getting inside the cath lab for the first time, even if you read everything, it's intimidating. The same for CT, the first time is intimidating. And obviously you've been an amazing teacher on CT and intervention, and you have been walking people through from novice to getting a decent understanding of how to do it. So since you've done it and you taught it, what do you think is the best way for people to get this done? And I know this is going to be actually part of the next podcast as well.
Yeah, everybody has a different journey, and I like your point about of like staying relevant. We want to use the oldest technologies available that we have at hand. And there's all this array of technologies, right? Outside the cath lab, inside the cath lab. And we just saw, it used to be that there was a lot of the innovation was largely in the structural field. But I think we're in a very rich moment in coronary interventions that increasingly we're seeing a lot of modalities both for diagnosis and treatment. And one of those areas is CT. So part of the reason, we want to stay relevant is because at this point, there's a lot of good data that intravascular imaging improves outcomes for these patients. We've known this for things like IVUS that has a lot of data, for example. And now, even in the guidelines, it's class 1 to use intravascular imaging. And of course, it's arguably it's fair point to say to reduce some of the hype with CT, we still have to see those trials. With CT, there's like the P4 ongoing trial of CT-guided versus IVUS for non-inferiority and whatnot, and other efforts from an investigational perspective. But irrespective of that, it is clear that no matter the modality, coronary imaging, and you can characterize these features and learn how to look at these things can be very valuable. And what I like to say, again, you had your journey. I'll tell you my journey. My journey of how I got started with this is, again, of course, I've been in practice for 8-9 years or something like that. I had trained level 2 in CT, and I've always believed in intravascular imaging, and I feel that every year I had gone more from like 70, 80, 90, that almost everybody that had PCI had some sort of imaging modality, more than norm rather than not. And by the time I came back to Minneapolis, of course, people know that I'm very passionate about the value of both coronary imaging and physiology, and actually to your point, like somebody like John last year had been using FFRCT for about 10 years or so, so a lot of experience. And it was around that time that, and this is something that we'll be talking in other episodes, this issue of virtual PCI and FFRCT, right technology at the right time, was brought up to me as an opportunity. Is this something that I can bring up to the cath lab, and of course, we'll share some of that information in our website. But this issue of virtual PCI was now making it very easy with 3D models to understand where were the lesions, where was the lesion drop of FRCT, was this focal or diffuse, were there tandem lesions, and how to offer the best results for the patients. And it was that improvement in technology iteration from going from FFRCT 1.0 to FFRCT 2.0 that you incorporate now virtual PCI that really opened at least my eyes in my journey to like, all right, we need to go back to understand what are the opportunities from CTs and trying to figure out how to integrate this to the cath lab. And this has created a great momentum because it has really developed a number of great relationships and collaborations from people around the globe. One of those is, soon after that started with us here in Minneapolis, actually I traveled to Belgium with our good friend Carlos. He's been doing a lot of this stuff, and Carlos Colette et al. And, he shared his approach of how they were doing this. They were adding a lot of elements that they were adding. They were adding things like, myocardial mass and other ways to characterize plaque. And it's been really a great number of ways to incorporate this into the clinical practice. Clearly, at this point, I would say in a simple manner, there's a practical way to do CT-guided PCI with the tools available at hand. With a basic CT reading software, one can understand what guide you need, what case complexity there is with respect to calcium, and you can assess morphology, length, and diameter. Now, beyond that, and we should discuss more of this in the future, there's all this array of emerging things, of advanced calcium modification and myocardial mass and CTO characterization and whatnot. But what is clear, and that's, you guys have used this term I like to use. Why was I convinced that we should adopt this technology early rather than later? Was because, of course, we want to do the science, we want to do the trials, etc. But it took few cases of really jumping into CT-guided PCI that we could really use this as a great triage tool. So as soon as I learned what I was looking for in the CT, I could look at a CT and say, all right, based on these features, I know where should I do this case. Should I do this at the mothership, or should I do it or is it okay to do this at the satellite hospital with potentially fewer resources? When should I do this case? I mean, like the cases that you do, some of your complex cases, imagine, you would love to know, I want to do this ambiguous 50 millimeter CT on Monday at 8 a.m. well caffeinated rather than Friday add-on case if they had a CT. And I would say you would probably be shooting yourself in the foot if you knew the patient had a CT and it's a long lesion, and why are you doing this case later rather than early? So it's a great triage tool for where you want to do it, when do what location, what equipment you need, and also even operators. So, but again, to me, triage was the one reason to consider incorporated this early. How have you incorporated this into your practice?
No, same thing. And I think, in the interest of time, and I think we shouldn't give it all away, right? The people will get too much. But I think we'll discuss about the how in the next one. But I think I'm exactly like you. I think the key benefits of this is, number one, that you understand what you're dealing with. Number two, you can discuss with the patient. Number three, you can plan your day, your cath lab, and they know expect a complex case or not. Now, as you know, it's not always perfect. Sometimes cases may appear to be one way or another on CT, and there's some surprise in the lab. So I don't think we're yet at replacing diagnostic angiography. But in most cases, it's fairly accurate and provides you a good sense for incorporating. So I think to summarize, why CT? For many reasons. Now it's very timely because technology is mature, because the patient outcomes will be better, because our efficiency and our productivity and also the safety for the patients will be improved if we know what we're dealing with. And if I can add a fourth component, I think it's also fun. Coronary has made some progress, but not as many as, for example, structural. And this is a whole new area to learn and explore, and there's nothing more fun than learning.
This is great, Manos. Thank you to everybody for joining us to the Coronary Corner by SYSTOLE. Some material will be available online, so feel free to take a look at that. Thank you.